Okay, we're going to call the hearing to order. Thank you all for being here this morning. Good morning and welcome. Today's Subcommittee on Communications and Technology and Subcommittee on Health joint hearing on the 21st Century Technologies for 21st Century Cures. I'd like to thank all of our witnesses for testifying today. Your testimony is extraordinary and most helpful in our endeavors. When Chairman Upton and I announced we would begin the process of updating the Communications Act, we knew it would be a difficult but much needed process. So I'm pleased today to be joining the Communications Act update with another important Energy and Commerce Committee initiative, 21st Century Cures. The communications and technology sector has been an enormous boost to our nation's struggling economy, due in part to the high investment and innovation in wireless technology and other devices. As we craft the legislation to update our laws, it's essential to hear from a wide variety of people who are on the front lines of developing and using these types of technologies in all spaces. Their unique viewpoints and expertise will help inform our consideration as we move forward, as well as underscore exactly why we've undertaken these challenging efforts to revamp existing laws. It makes sense to unite these two initiatives as they're both critically important not only to industries that are crucial to the economy, but also for every person here. This is an opportunity to recognize the benefits wireless smartphones and devices can provide to improve an individual's health and the healthcare community. We've seen examples of this intersection already, from wearable devices that track activity to the use of mobile apps reminding users of their individual health needs to a patient's ability to easily and remotely communicate with their doctor through a telehealth device. The growth in this area has been remarkable. There is a technological revolution happening in the healthcare space. In the communications and technology world, there's been a good deal of focus on the so-called virtuous cycle of technology. That is, the investment in devices and networks creates opportunities for app developers to create new and innovative uses for these devices, driving demand from consumers, which then spurs further investment. The health technology field is the perfect setting for this engine of invention and development. As healthcare technologies proliferate, patients, doctors, and researchers will realize the potential for the technology, and as a result, demand will increase. Increased demand means even greater incentive for investors to place their bets on the technology, which in turn spurs the cycle even further. In reading the testimony submitted by our witnesses in advance of today's hearing, I was impressed by what they can already do in the healthcare field using technology that exists and what the potential is as we develop. In Mr. Meisner's written testimony, he describes how leveraging cloud technology allowed scientists to conduct an experiment at a cost that was orders of magnitude less and that it would have been had using traditional data center and infrastructure. And I believe it was 39 years compressed into 9 hours. This is exactly what we're hoping to learn about today in more detail and how we can take advantage of these opportunities. With that, again, thank you for being here, and I now recognize Mr. Pallone for 3 minutes.
Thank you. Thank you, Chairman Pitts and Chairman Walden. We're here today to discuss the ways in which promising new technologies may be harnessed by the healthcare industry to provide better quality care, inform healthcare research, and empower Americans to better maintain their own health. The Subcommittee on Health has explored this issue in a number of different hearings this Congress, most recently in April when we examined how 21st century technology can benefit patients. And what we learned to date, and what I hope we'll hear more about today, is that these technologies may not just improve patient outcomes, but also have the potential to bring down the cost of care for everyday Americans and for the nation. Many health systems are responding to the Affordable Care Act's call to reduce costs and improve quality by adopting the use of technologies like electronic health records, health analytics, telemedicine, and mobile health applications. By monitoring patient progress in real time, providers will limit costly readmissions and prevent the onset of advanced stages of disease. In fact, declining readmission rates played a significant role in slowing the growth of our nation's health spending in the years following passage of the ACA, and in the long-term budget outlook published Tuesday, the CBO found that the decline in our health spending will allow the Medicare Trust Fund to remain solvent for an additional 6 years. And this testifies to how the law is pushing providers to improve the quality of care, but also to the potential of health technology like telemedicine and patient tracking systems to relieve the financial burden of preventable conditions on the entire healthcare system. In keeping with the ACA's embrace of preventive care, many of these technologies will keep people healthy and enable patients with chronic disease to better manage their conditions on their own. The CDC estimates that 133 million Americans live with at least one chronic illness disease, like diabetes, heart disease, and cancer, and the treatment of chronic illness accounts for more than 75% of all health spending. So it should be clear that keeping Americans healthy must be a national priority. Additionally, with access to quality data, health researchers at the NIH and throughout the country will be better able to study the range of conditions which afflict Americans, research that can be used to develop more effective treatments and inform the practice of evidence-based medicine. Meanwhile, health analytics will allow insurers to design value-based benefit plans which will reimburse providers for the quality and not the quantity of care they render. And with this monetary incentive, providers will more often invest in an ounce of prevention than wait to deliver a pound of care. Many of the technologies discussed today can improve Americans' health, yet we must remember that the adoption of technology for its own sake does little good and can contribute to the escalating cost of medicine. We have to work to ensure that advances in health technology serve to improve all Americans' health, stopping the onset of preventable conditions while not exacerbating health disparities along socioeconomic lines. And further, we must make certain that the transfer of these data and doctor-patient communications complies with federal regulations and that federal law ensures the confidentiality of patient data. Our witnesses today represent firms developing these technologies, and I thank them for their testimony as well as their efforts to improve Americans' health. And, Mr. Chairman, I'm looking forward to hearing what is now in the field and how this further contributes to the past work of our committee. Thank you.
Thank you, Mr. Pallone. Appreciate that. I will go to the chairman of the Health Subcommittee, Mr. Pitts, for opening statement.
Thank the chairman for this joint hearing of the subcommittees on communications and technology and health, and welcome all of our witnesses here this morning. As part of our committee's 21st Century Cures Initiative, we are examining the discovery, development, and delivery process to speed new treatments and cures to patients. One of the most promising avenues to facilitate this goal is new technology. And we're witnessing the impact of that technological innovation that it has played in every aspect of our economy. Technology has the potential to transform healthcare as well, and in doing so, address many of the challenges that we currently face. The question before us is, how do we ensure that our healthcare system can take advantage of the innovation going on in the tech world? We now have mobile medical apps that can make healthcare more personalized if we don't overregulate them. We have electronic health records that can be shared among various providers to help better coordinate the care we receive if we can ensure they are interoperable. These and other technologies hold great potential for the future of healthcare and personalized medicine. In order to realize this potential, however, we are going to have to address barriers that currently make full integration difficult. Our witnesses are here today to help us think through these technologies and the role they can play in a 21st century healthcare system. So I thank all of the witnesses for being here today, and as I yield back, I ask for unanimous consent to submit for the record a letter from the Telecommunications Industry Association.
Without objection, so ordered. We now turn to the gentlelady, my friend from California, Ms. Eshu, for opening comments.
Thank you, Mr. Chairman, and welcome to the witnesses. And I want to thank the leaders of the two subcommittees for having this joint hearing. I think it's a terrific idea and an important one. To talk about the combination, the intersection of technology and medicine. And I think that in both areas it represents American genius, and that's why I find it so exciting. My Silicon Valley district is the home of modern-day innovation. It really is the innovation capital of our country, of the world. It embodies an entrepreneurial spirit, and it attracts those who identify challenges and turn them into opportunities. They drive new technologies, expand education, and find creative ways to build a better world and to improve humankind. The Valley has a long history of pioneering technological advancements. After World War II, the development of the semiconductor industry, which is really the foundation of Silicon Valley, led the way to the desktop computer and then to the explosion of the Internet, which continues to flourish. And I could tick off a whole list of honor roll names of companies that are identified with the Valley. What's equally important, in my view, in Silicon Valley, and it's not always widely recognized, is the parallel advancements in healthcare. My district is the birthplace of biotechnology in our country, and we have more biotechnology companies there than any other place in the country and in the world. So it's an eloquent statement about the region and what takes place. There are hundreds of young companies developing the latest therapeutics, medical devices, diagnostics, genomic tests, and wireless healthcare technologies. And the ability for these two industries, high technology and healthcare, to mature side by side has really yielded, I think, unparalleled advancements for patients and dramatically improved healthcare outcomes. So the whole issue of the power of broadband and wireless connectivity, it's the intersection of technology and healthcare, I think is more dynamic than ever. In Mountain View in my district, iHealth's blood pressure monitor is empowering individuals to take charge of their health care by wirelessly connecting this data to a smartphone. That used to be for James Bond. Now it's for the average person. Similarly, Proteus, a Redwood City-based company, is improving patient care through an ingestible sensor which wirelessly sends information using Bluetooth technology. I mean, this it really is. It's not only cutting edge; it's exciting and it's important. I'm very proud to have Dr. Dan Ruskin here today from my district testifying. Thank you for coming across the country to do so. He's a serial entrepreneur. He's the founder of Health Fidelity and consulting faculty at Stanford University School of Medicine. So thank you, Dr. Ruskin. And he serves on eHealth Initiative Leadership Council and collaborated with the Bipartisan Policy Center on their oversight framework for assuring patient safety in health information technology. Geez, I thought only in government did we have long titles like this, but I guess it's in academia as well. So I welcome all the distinguished witnesses here today. And again, I thank the leadership of both of the subcommittees for putting this important hearing together.
Thank you, Anna.
And I yield.
Thank the gentlelady. We now turn to the chairman of the full committee, the gentleman from Michigan, Mr. Upton.
Well, thank you, Mr. Chairman. With this hearing, we're going to continue our commitment to modernizing laws and regulations to keep pace with the breakneck speed of the innovation era. Two leading initiatives have been our COM Act update, which seeks to update the 80-year-old laws governing the communications and technology sectors, and obviously 21st Century Cures, which aims to accelerate the pace of cures and treatments. Today, we have the unique opportunity to bring together two of our subcommittees and look at the intersection of these efforts and the ways in which new technology is enabling remarkable advances in medical care and treatment and research. Our witnesses include established tech companies that are hoping to bring their expertise to bear on the challenges of modern healthcare, as well as startups that are focused solely on tech solutions for patients and clinicians. From electronic health records to cloud storage of genome research and apps that identify preventative health strategies, we're looking at the future of medicine. Technology is supporting proactive solutions, collaborative research, and improved communications between patients and their physicians. Our committee has gone great lengths to encourage investment and innovation in the U.S. tech sector, and there are few applications of that work more important than the health of all Americans. We have the opportunity to not only enable new cures, but accelerate the pace at which they're realized. By taking full advantage of available technology, the possibilities for the future of healthcare indeed gives us hope. In June, we held a roundtable to explore the opportunities and obstacles surrounding digital healthcare, and I look forward to continuing that conversation. It is my hope that this hearing, like the roundtable, will help us identify ways in which this committee and the Congress can support the adoption of life-saving technologies in the healthcare sector. I thank you all for being here, and I yield back the balance of my time.
Gentleman yields back the balance of time. Chair now recognizes the distinguished gentleman and former chairman of the committee, Mr. Waxman, for 3 minutes.
Thank you very much, Mr. Chairman. This joint subcommittee hearing is a chance for members to learn more about the technological innovation taking place in our healthcare system. Technology can play an important role in expanding access to care, improving the quality of care, improving health outcomes, and reducing costs. In recent years, we've witnessed incredible innovation in our healthcare system. Venture capital funding for digital health companies is at a record level. New innovators are entering the industry every day. And it is not a coincidence that all of this innovation has occurred in the years since we passed the Affordable Care Act. As the managing director of a major startup incubator put it, quote, "We're seeing a lot of tailwinds from the healthcare reform. It has put a lot of pressure on existing stakeholders to reduce costs," end quote. It's also not a coincidence that this innovation is occurring following our unprecedented investment in expanding the use of health information technology through the Recovery Act. The number of doctors using these technologies has quadrupled in just 3 years. The percentage of hospitals using them has grown from 16% to 94%. It's not a coincidence that we've seen all of this innovation with FDA and the FCC offering important guidance and using their enforcement discretion wisely. And it is not a coincidence that we have seen this innovation at the same time that HHS has opened up vast amounts of data to the public, while recognizing innovation with awards and grants to help startups shake up the health system. I mention these important ways the federal government has helped foster a climate of innovation because this hearing and the committee's 21st Century Cures initiative should focus on these successes. I look forward to hearing from today's witnesses about what needs to be done to continue these trends that are improving our healthcare system every day. We should legislate only where appropriate and necessary. Otherwise, we risk jeopardizing the integrity of a system that is already functioning quite well. Thank you, Mr. Chairman. Yield back.
Thank the gentleman for his opening comments. And now we'll go directly to the witnesses. Thank you all again for submitting your testimony in advance. We appreciate that. And we'll open up with Mr. Dave Wachtel. Is that right? Did I say that correctly? And turn on that microphone. Chief Executive Officer of Life Channel. We're delighted to have you here. Please proceed.
Good morning, Chairman Walden and Pitts. I'm Dave Wachtel, the CEO and founder of Life Channel, Inc. It's a great honor for me to be here today, and I want to thank you for the opportunity to testify on this very important topic of innovative technology and the current and potential impact to population health. I'd like to briefly cover 3 topics today. First, a short overview of Life Channel to give you some context as to the role that startups can play in the rapidly evolving healthcare delivery landscape. Second, I'll cover 3 lessons learned and the so what that might inform how you evaluate health technology opportunities. And third, I'm going to share a list of large insiders who I think are forward thinkers and innovators in working with new technology and to try to discover what's next for healthcare delivery. Life Channel Inc. builds mobile patient programs that translate physician instruction into patient action. We help patients new to diabetes, prediabetes, COPD, heart health, and smoking cessation begin to build basic good habits to support their chronic conditions. We also operate a preventive health program targeting the chief health officer of a household. We create programs that connect the patient and their personal support team and their care providers through integration across mobile experiences and the provider's electronic health record. Over the past 3 years, we've worked closely with patients, pharma companies, government agencies, payers, EHRs, providers, and other technology companies to translate changes in technology and consumer behavior into opportunities to impact long-term health. We've learned 3 important lessons relevant to consumer-facing health. First, if you're not integrated into the existing patient flow, whether it be the physician or the provider or payer, it is almost impossible to become part of a patient's health journey. Consumer health actions are not only the behaviors that new technology companies need to engage, but they're also hospital procedures, billing protocols, prescribing habits, hundreds of habits within the system that we need to be a part of. Number two, technology doesn't change behavior. It just potentially creates a new access point to things that do change patient behavior. A cool app on your phone doesn't make you take your meds by reminding you or making a game out of it. You don't skip your Lipitor because it wasn't fun or because you forgot. You skip it for the basic human behavior that you feel great and you're not connecting your current health behavior to long-term health. Technology experiences that reinforce the drivers of good health behavior create patient-led, not technology-led solutions. And finally, there remains a strong economic incentive not to release the data that will drive patient insights and recommendations in the next 10 years. Many payers do not release claims data that could fuel incredible insights into pinpointing health intervention opportunities because they have a large business selling that data to pharma companies. Electronic health record companies don't make it simple to exchange data with other EHRs because it reduces switching costs of moving to a different HR for a hospital. There are a handful of innovative large institutions that unleashed great innovative momentum through aggressive piloting and partnership with third parties. And the pattern of their innovation is similar. They make public a problem they are trying to solve, they make data available to support solving that problem, and then they find a pathway to engaging technology innovators to solve that problem. Here are a couple examples of those leading innovators. The Office of Disease Prevention and Health Promotion, under the guidance of Linda Harris, Ellen Langens, and Celia Lear of the ODPHP, are pioneers in co-design of digital experiences incorporating health literacy principles. They not only engage third-party technology companies against the goal of the ODPHP, but also systematically share their learnings with other government and public sector groups to advance best practices in patient literacy around preventive health. Their My Family Mobile program has been in pilot for the past 10 months and is about to release version 2, which includes EHR integration and connectivity with the new Apple HealthKit platform. Boehringer Ingelheim, under the guidance of John Doniger and their new business model group, aggressively engages new technology companies to help his organization understand the role that pharma could play in healthcare delivery in 10 years. The Allscripts EHR platform, under the leadership of Tina Joros, has also embraced third-party developers and platform openness to tap into the power of technology innovators. Johnson & Johnson, Robert J. Wood Hospital System, Box, and CMS have also been aggressive in identifying problems, making data available to entrepreneurs, and helping them try to solve their hardest problems. In summary, we believe that technology companies that partner with large insiders and lead with patient behavior versus cool technology have the greatest opportunity to impact health outcomes in the next 10 years. There are some great innovators that should serve as a model, and no shortage of technology innovators with limitless energy and caffeine to try to impact population health. Thank you again to the chairpersons and members of the subcommittee for your time today and the opportunity to participate in this hearing. I would love to answer any questions you have. Thank you.
Thank you very much, Mr. Vogel. We appreciate your testimony as well. And now we're going to go to Mr. Riskin. We appreciate your being here, and founder of Health Fidelity. Thank you for being here, David. And Dan, I'm sorry. And turn that microphone on, pull it close, and we look forward to your comments.
Good morning, Chairman Walden.
You have to push the little button on there. One more time. We're a technology.
All right, how are we doing?
There we go.
Thank you. Good morning, Chairman Walden, Chairman Pitts, Ranking Member Eshoo, Ranking Member Pallone, and members of the subcommittees. It is an honor to testify. I am a serial entrepreneur, founder of Health Fidelity, a leading big data analytics company, and consulting faculty at Stanford University School of Medicine. In addition, I am a practicing physician, board certified in surgery, critical care, palliative care, and clinical informatics. I serve on eHealth Initiative Leadership Council and collaborated with Bipartisan Policy Center on their efforts toward patient safety and healthcare IT. I've been fortunate to succeed as an entrepreneur educator, and surgeon, and I'm grateful to the federal government for contributing to my success. I've been awarded multiple grants from the NIH and National Science Foundation, each grant resulting in creation of multiple long-standing, long-term, high-paying, skilled jobs. Every federal dollar received has resulted in $15 of follow-on private sector investment. These efforts have led to companies and products used at Harvard, Stanford, and other leading institutions to benefit patients and enhance medical knowledge. My background has afforded me unique insight into healthcare innovation in practice. 21st century technology in healthcare includes devices, data, information-enabled workflow. This newly emerging data-driven healthcare not only offers the right information at the right time for the right patient, but also provides a needed pathway for population health, analytics, and patient engagement. The goal is a more efficient, effective, and approachable healthcare system. Collaboration and innovation are required, and government has a critical role to play. Today, I will focus on 3 actionable recommendations to promote safe and meaningful innovation in healthcare. These include redefining interoperability to share the information that is needed for clinical analytics and population health, revising our approach to quality to better align with improved outcomes and reduced costs, and research to better understand safety in healthcare IT. I recently cared for a very nice woman who was failed by our healthcare system. A heart murmur had been noted during physical exam years earlier. Unfortunately, on changing her insurance, the information was buried and lost in medical documentation. Her failing heart valve was only discovered years later when she presented to the emergency department unable to breathe. She required an emergency operation, leading to an extended ICU stay and millions of dollars of taxpayer expense. If her condition had been recognized early and treated electively, the likely costs would have been far lower, and she and her family would have been spared a month-long stay in the hospital. I will discuss recommendations in the context of her case. The first actionable recommendation is a better definition of interoperability. Current efforts and proposed regulations focus on sharing patient summaries only. Unfortunately, there is simply not enough information in these summaries for innovative analytics companies like mine to promote data-driven healthcare. In this clinical case, an exam finding was documented in the physician narrative, but did not show up on the problem list and would not be present in an interoperable summary. To support interoperability of summaries only, as is proposed in current regulation, is to ignore critically important information such as home environment, medication compliance, exam findings, and hospital course. Innovation and care improvement will be hobbled for years to come by this arbitrary limitation. Through the Meaningful Use program, our country has subsidized electronic capture of clinical data. Why wouldn't we require that all data we paid to capture be available for use by innovative companies and technologies to actually improve care? The second actionable recommendation is an enhanced definition of quality. This patient's care met all process measures required. She had routine tests documented, counseling, weight documented, but did she receive great care? Quality measures are increasingly selected for feasibility, meaning we often select for what is easy to measure rather than what really influences outcomes. In this case, a relevant measure of quality would have been whether the patient received appropriate follow-up for her heart murmur. If quality measures are our national target, this is the time to refine our approach and require accurate and meaningful quality measures in healthcare. Finally, my patient's information was exposed to many healthcare software systems. Were these systems safe and effective? While the country defines a first-pass approach to healthcare IT safety, we must acknowledge these IT systems are new, innovative, and rapidly evolving. To refine our regulatory approach over time, we will need information on how and when healthcare software is safe versus potentially dangerous. Support of academic and clinical research in healthcare IT benefits and risks would go a long way to help us refine regulation over time. We're going in the right direction. Health systems, payers, and vendors are collaborating through new financing models and newly available data with new enthusiasm. But there's a great deal of work left to do if we are to bridge the gap from electronic information to better and more efficient care. I look forward to continuing to work with you to leverage our national HIT investment to create data-driven healthcare. The U.S. is well poised to revolutionize healthcare and to benefit our people and economy at home while showing global leadership in this critical industry.
Thank you very much, Ms. Riskin. We appreciate your testimony. We'll go now to Mr. Meisner, Vice President, Global Public Policy at Amazon. Paul, please go ahead. Thanks for being here.
Thank you, Chairman. Good morning, Chairman Walden, Chairman Pitts, and Ranking Members Eshu and Pallone. Subcommittees, my name is Paul Meisner, and I am the Vice President of Global Public Policy at Amazon.com. On behalf of Amazon and our customers, thank you for inviting me to testify today on how 21st century technology enables 21st century cures. After briefly describing cloud computing technology, my testimony will illustrate how innovative healthcare organizations, both large and small, established and startup, public and private, already use cloud computing to foster the innovation cycle of discovery, development, and delivery of new biomedical treatments and cures. I will conclude by suggesting 3 ways that Congress could help accelerate this cycle by adopting policies to facilitate use of cloud computing for healthcare. With cloud computing, information technology users, including healthcare enterprises, now can acquire technology resources such as compute power and storage on an as-needed basis instead of buying, owning, and maintaining their own data centers and servers. In 2006, Amazon's cloud computing business, Amazon Web Services, or AWS, began offering developer customers access to in-the-cloud infrastructure services. AWS now has hundreds of thousands of customers, including over 3,000 academic institutions and 800 government agencies. In the healthcare sector, enterprises of all sizes and types are beginning to use cloud computing technology for the discovery of new biomedical treatment and cures. As the chairman mentioned earlier, in 2013, Novartis scientists discovered a large molecule involved in the disease mechanism for a particular type of cancer. The scientists wanted to virtually screen 10 million compounds against the large molecule. Such a large number of screenings is extremely computationally intensive. Novartis did not have the capacity in their existing data center to do this type of test, and building new infrastructure would have cost an estimated $40 million. Instead, using AWS, they built a virtual high-performance computing center in the cloud and were able to perform the equivalent of 39 years of science in less than half a day and for under $5,000. Enterprises are also beginning to use cloud computing for the development of new biomedical treatments and cures. For example, in the summer of 2012, Merck was noticing higher than usual discard rates for certain vaccines. The high discard rates could result from many factors. Evaluating these factors for every vaccine produced was extremely challenging using a traditional spreadsheet approach. So instead, Merck worked with a partner to implement a cloud-based solution using AWS, and over a 3-month period, they were able to combine all of their data sources and perform over 15 billion calculations and more than 5.5 million vaccine batch-to-batch comparisons, and thus they were able to precisely identify how characteristics of fermentation had direct impact on vaccine discard rates. Lastly, enterprises are beginning to use cloud computing for the delivery of new biomedical treatments and cures. For example, the U.S. FDA, which receives 900,000 handwritten reports of adverse drug effects each year, needed a way to make the data entry process more efficient and reduce costs. Using AWS Cloud Computing, the FDA and Captricity quickly turned manual reports into machine-readable information, reducing costs from $29 per page to 25 cents per page. Chairman Walden and Chairman Pitts, please allow me to suggest 3 ways that Congress could help accelerate the innovation cycle of discovery, development, and delivery of new biomedical treatments and cures by facilitating the use of cloud computing for healthcare. First, to help accelerate the discovery of new biomedical treatments and cures, Congress could work with NIH to establish and operate cloud-based data management platforms to which federally funded researchers could upload their research data along with any relevant software resources required to reproduce their analysis of the data. Other researchers in the field could then access the data and software in order to reproduce the results, reanalyze previously collected data in novel ways, or even automate the analysis of new data using the same approach as the original experiment. Second, to accelerate the discovery and development of new biomedical treatments and cures, Congress could enact both H.R. 967 and H.R. 1232. These are bills that would assess and facilitate the use of cloud computing by federal science agencies. And third, to help accelerate the delivery of new biomedical treatments and cures, Congress could work with HHS to modernize implementation of HIPAA so that healthcare providers can readily employ the benefits of cloud computing. By narrowing the application of HIPAA to situations where cloud services providers have access to and knowledge of health information, time and money won't be wasted on contracts that are mostly inapplicable, And cloud services providers can more reasonably comply with HIPAA by focusing on areas where they actually have access and knowledge of health information. Chairman Walden and Chairman Pitts, thank you again for holding today's hearing and for inviting me to testify. I look forward to your questions.
Some wonderful recommendations. Thanks for your testimony. It's always impressive to see what's happening out there. For the members' benefit, we're about 10 minutes to go in the first vote, but we always know that takes a little longer, so we'll try and get through the witnesses if we can. We'll go now to Mr. Robert Jarin, Senior Director, Government Affairs, Qualcomm Incorporated. Thank you for being here. We look forward to your testimony.
Thank you, Chairman. Good morning, Chairman Walden and Chairman Pitts, Ranking Members Eshoo and Pallone, and members of the subcommittees. On behalf of Qualcomm, an American company and the world's largest wireless chipset supplier and largest licensor of mobile technology, it is an honor to be here again. Thank you for inviting me. Mobile technology, Qualcomm's specialty, has become the largest communications platform in the history of the world, and it continues to grow. Currently, there are 355 million connections in the U.S. and over 7 billion globally. We forget how quickly mobile technology has proliferated. The Android OS and Apple's iPhone were launched in 2007, the iPad in 2010. You wouldn't know it the way consumers rely upon these services and devices. Qualcomm can't make this happen by itself, which is why we work with many partners. I am pleased to be here today with one of them. It's Amazon.com. Their leading-edge Kindle Fire HDX tablet, Fire smartphone, and Fire TV media player all incorporate Qualcomm's innovative Snapdragon chipsets. Qualcomm's technologies are found in products that touch every aspect of society, including healthcare, which is why in 2011 we launched Qualcomm Life, a wholly owned subsidiary focused on medical device connectivity and management of health data. At Qualcomm, we understand that nothing can transform a sector like mobile 3G and 4G technologies. Healthcare is a good example, one in which I have personal experience. On August 16, 2006, my mother was diagnosed with stage 3C late-term ovarian cancer. She was 65, a widow with limited English proficiency. From the start of her odyssey, I discovered that doctors, clinics, and hospitals were not sharing her healthcare information. I was struck by the lack of continuity of care. When she left a care provider or facility, there was no mechanism to remotely monitor her basic physiological status. This seemed dangerous in light of countless doses of chemotherapy, protein inhibitors, and toxic serums she endured, which caused horrible side effects, including extreme high blood pressure and edema. In the years since my mom's initial diagnosis, mobile computing devices have helped personalize healthcare. Remote patient monitoring is now helping drive systemic changes in healthcare networks. Platforms such as Qualcomm Life's Healthy Circles facilitate the management and sharing of medical information between stakeholders across the patient's healthcare community. Qualcomm Life and its partners produce novel, commercially available 21st-century mobile medical solutions such as mobile ECG recorders, wireless telemetry sensors, mobile glucose monitors, software systems that deliver live patient data to a doctor's smartphone, smart inhalers, radiological imaging viewers for mobile devices, and implantable pulmonary sensors that communicate wirelessly with bedside monitors. The future is even more exciting. The X Prize Foundation and Qualcomm developed a $10 million competition, the Qualcomm Tricorder X Prize, to produce a device that can diagnose 15 distinct diseases in a group of 15 to 30 people within 3 days by a consumer, independently of a healthcare worker or facility. If investments are any sign of the future, the first half of this year shows 143 companies having raised $2.3 billion year to date, thus eclipsing the 2013 total of $2 billion. Those investments include some by the Qualcomm Life Fund, which was formed in 2011 and is now considered one of the most prolific investors in wireless health. However, challenges do persist. Lack of reimbursement is a major barrier to telehealth and remote patient monitoring technologies. Medicare telehealth provisions in the Social Security Act are overly restrictive and exclude the majority of these technological innovations, and that needs to be changed. Another is the Center for Medicare and Medicaid Services EHR Incentive Payment Program, popularly referred to as Meaningful Use rules, which do not include the ability to upload patient-generated health data into certified EHRs. Future stages of the program should specify the incorporation of patient-generated health data from home-use medical devices into EHRs. Another important issue is spectrum, the lifeblood of our wireless networks. Qualcomm commends this committee and Congress for all the work it's doing to make additional mobile broadband spectrum available. This work is critically important. In closing, the speed of innovation should never come at the expense of patient safety. Health IT software and mobile medical apps developers should support data collection and quality mechanisms to foster patient safety and create a learning environment. Nearly 8 years after my mom's diagnosis, I'm thankful to her healthcare team that she's continuing to live an enjoyable life. I'm also grateful for the advancements in 21st century medical technologies that are helping society as a whole. Qualcomm has played a significant role in mobilizing healthcare to improve lives and advance digital medicine, and it will continue to do so. Thank you. I look forward to your questions.
Jaron, thank you, and that's good news on your mother. Having lost a mother to ovarian cancer, I know how awful that is and the treatments can be. So I'm glad to hear your mother's doing well. We'll now go to Dr. Jonathan Nyloff, Chief Medical Officer and Vice President, McKesson Connected Care and Analytics, McKesson Corporation. For our members, the Whip's office will keep the vote open until we get there so we can conclude with our final witness this morning. So, Mr. Nyloff, thank you.
Thank you. Good morning, Chairman. Pardon me. Good morning, Chairman Walden and Pitts, Ranking Members Pallone and Eshoo, and distinguished members of the subcommittees. I appreciate the opportunity to appear before you today. Throughout my career as a gynecologic oncologist in Boston, faculty member at Harvard Medical School, and founder of a small health IT company, I have seen firsthand the power of IT to improve outcomes, reduce costs, and accelerate the pace of change in our healthcare system. As the largest health IT company in the world, McKesson is focused on the transformation of healthcare from a system burdened by paper to one empowered by interoperable electronic solutions. There is a significant opportunity to improve our healthcare system, but to do so, we must fundamentally transform how care is delivered. We need to move from a fragmented model of care where each patient visit is disconnected to a model where care is coordinated across the entire continuum. Interoperable health IT is foundational to this transformation. I would like to share today 2 recommendations which will advance healthcare in the 21st century. First, we must align payment and coordinated care models in order to create an environment that fosters interoperability. And second, we need a new risk-based regulatory framework that is specific to health IT. We don't today have an easy, uniform way to move patient data between care settings. The interoperability we need requires collaboration among all stakeholders to develop uniform standards, coordinated policies, and the necessary infrastructure to promote interoperability and assure coordination of care. ONC has provided an important role in providing common guardrails for the exchange of health information. It is important that we maintain flexibility within those guardrails to allow for industry innovation. One example of innovation and interoperability is the Commonwealth Health Alliance. Commonwealth was founded by McKesson in partnership with our competitors to develop a software solution that will share patients' data with their consent across multiple settings of care. We've made significant progress in this endeavor over the last 18 months. It is essential that we are able to share the right patient data in the right place and the right time. This solution is imperative to creating a new model of coordinating care. Fostering innovation in the private sector is critical, but there is also a role for Congress to play. Policy changes are needed to reflect current advances in technology and promote ongoing innovation. A 21st century health system demands 21st century policies. We support a new regulatory framework that would establish 3 categories of health IT. Oversight of each category would vary according to potential risk to patients and the role of the clinician. The FDA should continue its important role in regulating software with the highest potential risk. However, we believe Congress should amend the Food, Drug, and Cosmetic Act to define each of these categories of health IT and provide clarity that clinical and administrative software should not be regulated as medical devices. To realize a true 21st century healthcare system, we need fundamental change in our healthcare delivery model. We need to replace our fragmented system with patient-centric coordinated care. This transformation has begun, but we need to accelerate the pace of change, and to do this, we must harness the power of technology. Specifically, We must align reimbursement and payment models to promote the adoption and also the interoperability of health IT. And Congress must update the law to codify how health IT is regulated in a way that, while assuring patient safety, is predictable and fosters innovation. The result will be better outcomes, better access, better cost efficiency, and better experiences for patients and their families. Thank you for the opportunity to testify today.
Dr. Nyloff, thank you for your testimony. Thanks to all our witnesses. We will go vote, and then members will come back and ask questions. We're probably going to be gone at least a half an hour, I would assume. So if you need to take a break, it's a good time. We'll reconvene immediately after votes. Thank you very much. We stand in recess.
Nice job. 7 seconds left. That was great.
Okay.
No, that was perfect. No, I think it was good. There's a lot of interest. Eshu, who's a good friend of ours in the white shirt, she's the one who's going to probably ask about why does it need the devices. But you have half. Why does it need? Why should software not be regulated as a medical device?
Right. Yeah.
So I didn't think that. I talked to him for an hour and a half about a year and a half ago, and he said, we got to do something about this issue. He said, he said, in the technology and communication spaces, he used to own a wireless radio company and stations in Eastern Oregon. He's the only Republican in Oregon. He's a very moderate Republican in Oregon. And just a down-to-earth, nicest, well, you could see the fact that he was, commented on his mother, and the fact that he'd lost his mother to ovarian cancer. I mean, it's just it's a lot of personal stuff that comes out and things like that.
The gynecological oncologist was probably not lost on him.
I'm sure it wasn't.
Yeah.
I'm sure it wasn't lost on him. I'm sure that Ray would appreciate all the research that you've done. And endorsement. Sue's husband died of the same thing my husband did. He had MDS that was going into leukemia. And her husband, Bob Massui, was a member of Congress for a long time. So she just took his spot out of Sacramento and represents our West Sacramento Distribution Center. So we spent a fair amount of time talking to her about issues. And plus she's involved in national marrow donor stuff that I do on the board stuff. Oh, we are. In Iowa, we're 350 employees. I could go down and tell you how many. We have employees in every congressional district in the United States. So believe me, I have all that mapped out in my mind. But we also focus on where we have facilities, and we have a couple major facilities in Diana DeGette's area in Denver, and Gene Green right outside of Houston, and Cassidy's area in Louisiana. And so he's a very interesting questioner, Cassidy. He is a policy wonk, and he'll sometimes ask questions. You go, what is he trying to do? What is he trying to get at? He uses health IT at Baton Rouge Memorial Hospital. He's also a big 340B. He hates 340B. Sorry, U.S. Oncology. So just ignore the 340. I'm sure he won't bring it up. I can't mention it. He's also running for the Senate against Mary Landrieu. We've supported Landrieu against Cassidy. But we've supported Cassidy in the past. He's a good guy. He understands the House.
Ladies and gentlemen, we're going to get started here with the hearing. If you want to go ahead and take your seats, we'll get our witnesses back. Our members are here. I'm sure we'll have some members making their way back from the series of votes we just had, but it's important that we continue our business. So I'll call the subcommittee back to order and appreciate, again, the testimony of our extraordinarily distinguished panel of witnesses. Thank you very much. And don't think you're off the hook, because I think what you've given us here is very important, and we will be following up, I'm sure, over the months and years ahead to dive deeper with you and how we can all get this right. I'm going to start off with questions, and the first one goes to Mr. Meisner. Are there any laws or regulations that have impacted the development of the cloud that we should take a look at deeply, change, that hinder what we're trying to accomplish here, what you're trying to accomplish here. I'm not talking about, obviously we got to protect data and privacy and security and all that, but are there other things we should be aware of that would facilitate advancements in the sectors we're talking about today?
Yes, Mr. Chairman, thank you for the question. I think government could serve as...
Not sure your mic's on. It may just need to be closer.
It's on.
Yeah, just closer.
Okay, here
That's
we go.
all.
First of all, thank you for the question, Mr. Chairman. There are areas in which government could provide an example to private industry. And one particular roadblock we've run up against over the years trying to serve government institutions, including the U.S. federal government and its agencies, is that there's oftentimes money set aside for agencies to buy computers, to buy software, to invest capital, essentially, which is highly inefficient when instead money could be allocated for purchasing service, making it an operational cost rather than a capital investment. And the government could not only be able to be much more flexible that way, in other words, only purchase what is needed and then discard it if it's not needed, but also it allows government to scale up and scale down as necessary. But we've also often run into problems where agencies are only given authority to buy specific things like hardware or software, when actually they should be able to have the freedom to obtain services instead.
Got it. So on another issue, and back to you, Mr. Meisner, and if others want to weigh in on these subjects, please feel free to do so. But how can we modernize HIPAA to ensure that patient information is protected but that we can still utilize data? There are other countries that have laws that protect patients but also facilitate data sharing and leveraging the research being done. I know in our roundtable that Chairman Upton convened recently, Dr. Brian Drucker, who heads the Knight Cancer Research Center in Oregon, talked about, I think it's 65 petabytes, did I say that right, of data just involving cancer patients that could be harnessed to do analytic work and all and research. Are there some issues with HIPAA? Are there some things we should be looking at in that respect?
There are, Mr. Chairman. It's not a huge barrier at this point, but what we would like to be able to do is recognize that there are some times when information is stored in the cloud where it is known to be health information and it's accessible to the cloud service provider. But most of the time that's not the case. We don't know what information is stored there, and it's also encrypted, so we can't get at it. And yet we still have to go through HIPAA hoops as if we had access to the information.
So what would that mean in real layman's terms?
Or it means that the healthcare enterprise that is storing data on our servers has HIPAA requirements placed upon it, but those requirements are also placed on a cloud services provider, even though it's entirely unnecessary. We can't see that data, and usually we don't even know it's there.
From a practical standpoint, what does that mean in your company?
I think it means asking NIH not to interpret the rules so broadly as to require a cloud services provider to comply with HIPAA where it's not necessary. But of course, we do comply with HIPAA, Amazon Web Services does, when it is necessary.
Okay. Dr. Nyloff, what are the technical challenges your company is facing as you work to innovate in healthcare that we might need to take a look at, besides what you outlined in your testimony?
Sure. So I think the major technical challenges involve interoperability. And the typical environment in a healthcare system is very heterogeneous, with multiple different EMRs and multiple different other systems that we need to connect to. And
EMRs being electronic medical records?
That's correct, sir. Mm-hmm. Solving that challenge, the technical challenge of connecting such heterogeneous environments, is a big barrier today.
All right. Anybody else want to weigh in on these topics?
I would say from technology around the HIPAA question initially, the inability of patients to give up their right to privacy. Like the HIPAA requirements are kind of universal, whether it's I have a cold or whether I have HIV. And there are some conditions where, let's say I had celiac disease. I would love to tell everyone on earth that I have it, because most likely that's how I'm going to find out better ways to take care of myself. But because of HIPAA, I can't even email my doctor. And so I think if there were additional opportunities to, like a common, let's make it super simple. I want to email my doctor. He wants to email me back, but we don't because it's against HIPAA for him to send me health information. But both of us would agree that it's okay for me to talk about my kid's fever through email. And so I think what that kind of the example we have around regulation is that when the FDA kind of took their very vague, some mobile stuff might be good, some mobile stuff might not be good, and made it, we're all kind of hanging around, and said, all right, you guys can leave the room, you guys come in, we want to talk some more, and you guys stay close. That changing very gray to more black and white allowed a lot of people to innovate and build something and do stuff.
We did an oversight hearing on that very issue about a year ago because nobody was getting clarity whether your iPad was a medical device or not, and we got them to admit some of those.
Stood up and applauded, but I think similarly with HIPAA, if there could be another layer of
good point.
This is what's covered and this is what isn't, it's okay to email your doctor about your kid's flu.
Got it.
That would do a lot to create innovation points for better care.
All right, thank you. I've extended my time. I'll now turn to the gentleman from New Jersey, the ranking member on the Health Subcommittee, Mr. Pallone, for 5 minutes.
Thank you. Reading the testimony today, I was impressed by how much progress we're making towards a more technologically advanced, efficient healthcare system. And one important step the federal government is taking to encourage this innovation is to open up much of the data it collects to the public. That allows developers, programmers, and academics to dig into this data and develop new tools to help improve our system. I wanted to ask Mr. Vocal, can you talk more about how you will put this open data to use and the potential benefits of this increased transparency over the long term?
Yeah, thank you very much. Life Channel, about 6 months ago, CMS released the big data set around exactly what every provider for Medicare charges for every protocol. And a couple weeks ago at the Health Data Palooza, which is a lovely name that I think Todd Park came up with, that just government and public agencies come together to talk about the incredibly exciting topic of health data. They had a competition to say, for this big data set, who can make it into something super interesting? And Life Channel won, largely based on some research that we did at the International House of Pancakes. And kind of the good example that the CMS sets is they release data before it's totally perfect. They don't wait. The CMS data was 50% actionable, but they release it early, and they give entrepreneurs or any great data analytics house a chance to churn through it and pull out what they can and make recommendations on what the next version of the data should look like. And I think the more that holders of that health data are encouraged to kind of release it when it's excellent, not when it's perfect, will allow entrepreneurs to get up on it like a shark and reveal if there's something inside or help identify what the next round of it should look like.
All right. Well, thank you. I think the steps that CMS and the other federal agencies have taken in this area are really important. I wanted to ask Dr. Riskin, in your testimony you state that health quality measures are often selected because they're easy to track. Could you elaborate on your recommendation that we need more accurate and meaningful quality measures in healthcare?
Yes, thank you for your question, Mr. Pallone. The challenge is whether we try to develop measures for what is easy to do today or whether we create a target for what we need to do to improve healthcare. If we create a target for what we need to do to improve healthcare, we won't be able to hit it today. The technology doesn't exist. If we don't, if we pick what's easy, then we won't actually meaningfully reduce costs in healthcare in the short term. So to give an example, a easy quality measure would be, are you counseling people for smoking cessation? And a hospital might meet that measure by on every discharge summary writing, you should not smoke. That doesn't do a lot of good if it's buried 5 pages down and mostly put in for non-smokers anyway. On the other hand, if the measure is, do you smoke, and that ties to an outcome like reduced costs and improved quality of care, that's the kind of measure that's meaningful. We don't do a lot of that because it's so hard for an EHR to measure, but over time the really robust analytics companies will figure out a way to hit that target if the government makes that known that that's the target to hit.
Thanks. And Mr. Jaron, In September last year, FDA issued a final guidance on mobile medical applications. It provides a long list of applications that FDA does not intend to regulate at all. Basically, I just wanted to get your views on this guidance. I mean, do you think that the FDA struck a proper balance between protecting patient safety on the one hand and allowing innovation to flourish on the other? And do you see any risks in trying to legislate in this area?
I think FDA did a good job by issuing the final guidance on mobile medical applications. It was definitely very different from the original draft. The original draft basically just restated the law without any clarity and without any vivid example. In the final draft guidance, they provided numerous examples of what they were putting under enforcement discretion being the ability for the agency to state publicly, we are not going to obligate regulatory requirements on certain medical devices, even though by definition they are medical devices. We're not going to require regulatory obligations. So I think that was very helpful to the industry.
What about the risk, though, in trying to legislate in this area?
I'm not sure I would say that there's a risk in legislating the area. I think that was the next evolution to what Congress had originally intended through FIDASIA. Through FIDASIA, they had asked for a risk-based regulatory framework. The agencies then came out with that through the FIDASIA draft report that they are contemplating currently. I think it's now the next step for Congress to decide whether it would like to go in and make those recommendations, codify them. So that's a higher pay grade than me. So.
Thank you. Thank you, Mr. Chairman.
Chair, thanks, gentlemen. I'll recognize myself 5 minutes for questions. Mr. Meisner, in your testimony, you suggest that Congress work with NIH to establish and support the cloud-based management platforms. Can you expound a little bit more on why you think this is so important? What's some of the benefits cloud-based platforms might lend to 21st century cures?
Thank you, Chairman Pitts. Modern biomedical research is a highly collaborative process. All scientific research these days is collaborative. The days of a major breakthrough coming from an individual working with a Bunsen burner and a test tube, it's over. You only need to look at some of the scientific journals and see the lists of authors. It's no longer unusual to see hundreds of authors listed in a major scientific paper, even over 1,000. And so that kind of co-research requires collaboration. And if the federal government can establish a way for federally funded researchers to share their information, even outside their normal channels of collaboration, it'll become far more efficient and more productive.
And you mentioned one other concrete step that you recommended as we decide if we decide to support this endeavor. List some other concrete steps that Congress can take. One was clarifying HIPAA. What are others?
Well, there are two bills that the House has already addressed, and hopefully they'll be addressed in the Senate as well, that actually would assess the government's provision or accommodation of cloud computing for scientific agencies, and another would clarify government agencies' ability to obtain cloud services in lieu of hardware and software. Both of those are important pieces of legislation, not only on their own merits and on their own rights of what's going on within the U.S. federal government, but as setting an example to state and local governments, to private industry, to governments in other countries, that there is a great deal of efficiency that can be gleaned from the cloud in dealing with that collaboration that I mentioned, and also just the massive amounts of data that now go into any form of scientific research, including biomedical research. So government setting an example, I think, is something that Congress can be part of right now.
Now, you mentioned Amazon worked with FDA to turn 900,000 handwritten reports of adverse drug effects each year into machine-readable information with 99.7% accuracy, reducing the cost from $29 per page to 25 cents per page. This Cures initiative is in part focused on using technology to relieve administrative burdens for agencies such as FDA, so they can use the resources, their resources to invest in more researchers and new development methods, such as biomarkers. Do you have other suggestions for other ways we can increase efficiency at FDA or other agencies?
Yes, Mr. Chairman. There's a model of scientists doing things that they don't need to be doing. One would be, for example, I don't know, producing their own electricity for their laboratories. You don't want them out in the back of the laboratory working on a diesel generator just so their labs have lights. Likewise, you don't want them to have to be tinkering with computing equipment, either for storage or computation, in a way that could easily be provided like a utility, like electricity. So let's figure out ways to allow our scientists to be scientists, our doctors to be doctors, and not have to have them be information technologists at the same time, even though, as part of the collaboration and the data-intensive work that they're doing, computation is absolutely necessary. It's just that they don't need to be the ones doing it.
Now, we talked a little bit about HIPAA. Are there other countries that have laws that protect patients but also facilitate data sharing, leveraging the research being done? Any of you who would like to?
Yeah, I'm not familiar with other countries' details.
Anyone familiar with other models? All right, let me just go finally. One common recommendation was for fully harnessing the potential of interoperable technology. Are we talking about just electronic health records, or do you think that medical devices, other healthcare sources of data should be interoperable? If you'll elaborate on that, any of you. Dr. Nyloff?
Yes, thank you. I think that the interoperability has to extend beyond just electronic health records. There are multiple sources of both clinical and non-clinical data that are important to aggregate together with the clinical data in electronic health records, and that interoperability should exist. There are also a variety of analytic solutions which are important to improving population health, so solutions that identify patients that are likely to be hospitalized, patients who are have progressing illnesses, and the ability to link clinical and claims data with those type of systems to allow the early proactive intervention in the care of those patients is a very valuable intervention to driving improved health, decreasing hospitalizations, and decreasing emergency room visits.
Chair, thanks, gentlemen. Now I recognize the gentlelady from California, Ms. Eshu, 5 minutes for questions.
Thank you, Mr. Chairman. I want to say to each of you, bravo. I think you have, every single one of you have been terrific witnesses. And you've given us, which is so important in a hearing, instead of starting with Adam and Eve, you've gone right into the meat of the subject matter to make recommendations for us. And that really is so helpful. So thank you to you. On this issue of interoperability, obviously there's more than one part of it. And what I wanted to ask you, Dr. Nyloff, is there anything that the government is doing today that stands in the way of interoperability as you just described it? I mean, i.e., in a patient's record, is a physician prohibited from putting in the last line? These are the most important things to track with this patient. I mean, I'm not a doctor, so I'm probably not stating it, as beautifully as I should. But I'm trying to figure out where we have regulations that need to be written, where we have regulations that don't make any sense anymore, or what we need to write and put on the books. And all of these areas are really important. So what, can you answer my question?
Sure, thank you. So electronic medical records typically have a lot of flexibility, but we are...
Thank you. I helped write the legislation on it, so nice to hear.
But You know, I think that with electronic health records and the rest of healthcare technology, we are at the beginning of a journey. And it's a journey that's going to take us many years to get to both to the level of sophistication in the solutions and in the level
but specifically, though, when it comes to interoperability and electronic health records, are there regulations that you think don't make sense? Or are you calling for something that will help advance interoperability? We deal with interoperability all the time at communications and technology relative to the telecommunications industry. This is a different deal. That's why I'm probing here.
So I think that the thing that will drive interoperability the most and where the government can have the greatest influence is in making the business case for interoperability for those who are going to pay for it. And what that means is that we need to align the payment models.
I think that for the most part now is private sector, though, because there were initial grants or whatever to get electronic records going. I think that money's been spent. So I don't think I don't think we're players in it.
If I may, I'm not talking about direct incentives. What I'm referring to is that
we need to speed it up. I have 1 minute and 20 seconds left. You've had 4 of my minutes almost.
Okay, I apologize.
That's all right. Go ahead.
How we pay for medicine, and what I mean by that is if we're doing a global payments, if we incent the delivery model to do a coordinated care model, and the payment is aligned with the coordinated care model, then we will drive the adoption of this type of technology.
Yeah. Well, thank you very much. To Dr. Riskin, I see you nodding, and I think you want to say something.
So to the same question, there are choices that are being made right now that could be better. So the choice for interoperability right now is we only share information out of the electronic health record that is perfectly structured, meaning only information.
So how do we make this more robust and meaningful so that the right information is extracted?
Sure.
Because that feeds through the whole system.
Sure. So if a doctor wrote right now, what's really important here is these 3 things, that would be ignored and never shared. What's needed
but the federal government shouldn't be instructing doctors how to write something.
Doesn't matter how the doctors will write what they write, but the federal government is instructing what needs to be shared in interoperable format.
So share is the operative word.
That's right. And if we share all of the information, then the analytics companies can pick up the useful information.
I just have so many questions, but my time has run out. I think what I'll do is to submit questions to you, both about the cloud, software, hardware. That's a whole other thing. I'm so thrilled that your mother, that you told a beautiful story. And it means a lot, I think, to all of us, certainly to you. Thank you, Mr. Chairman.
Chair, thanks, gentlelady. Now I recognize the gentleman from Illinois, Mr. Shimkus, 5 minutes for questions.
Thank you, Mr. Chairman. It's great to have you all here, and I'm going to try to be quick, too, but I'm going to just segue right after my colleague, Congressman Woman Eshu's question, and it's kind of getting out of order the way I wanted to go, but Mr. Riskin, this data information is really the crux, and so I'm concerned that or the question is, if you're going into the genomics debate and personalized medicine, the data, are we in the way because of HIPAA or some other rules and regs that we're afraid to put the data available to a larger field because of the rules and regs we have in place?
Yes, thank you for the question. Yes, certainly the privacy and security policies make it tougher to share data. With that said, I'm one of the biggest proponents of keeping data safe. We're asked as a big data company to use genomic data and combine that with phenotypic data, the clinical information, and figure out what it means. Keeping it safe is critically important. that doesn't mean that you shouldn't share it safely. So if the private sector can keep it safe and follow regulations to do that, but there's also a requirement that the information come out in certain formats so it can actually be used, that's a very powerful setup. So all of the data we've paid to collect can be used to do meaningful things.
So let me move to Mr. Meisner on kind of the same talk. So a lot of folks are afraid to go into this field because they've done a business analysis. They don't know if there's a return on investment. You guys have decided to try and move in this. So data storage and computation is the area that you think obviously can get you a business model plus improve. You know, I'm a market capitalist. So we don't get these investments unless there's a return on investment. We don't get that unless there's improved health access and the like. So is that the model, the business model that you think that you all can do, is this big data storage and computation while keeping that data safe and secure?
Yes, Mr. Shemkis, we very much believe in this business. We're very passionate about it as well. We kind of backed into it as a retail company online. We figured out at one point that, gee, we have a business in keeping data safe and organizing it and storing it and being very efficient about it. So we started making it this kind of a service available to developer customers. We think in the medical field, the medical sector, there are many opportunities for the storage and sharing of data in a way that is highly secure. We not only believe that security is incredibly important to our business, but it's actually much easier to do at scale. We have the ability to provide security measures in the cloud that just aren't available for local storage of information. And so we're passionate about it, and I think we're an enabler of the genius that you see at the table here.
Just because I want to get the last two in the mid-1970s, Congress defined medical devices, which I think for the most part people thought at that time was good and helpful. The question is it time for us to look at codifying terminologies to help us through these processes? I mean, a lot of this talk is about FDA and how do we expedite, but don't you think it might be a time to look at some new words and definitions that define them in the law so that we can get some application speedily? And I just kind of throw that up as a comment. Anyone want to jump in real quick? I got one more question, so if you can be brief. Dr. Nyloff?
Yes. So I believe that that's very important. You know, when I went to medical school, we didn't have computers. You know, this is all new stuff, and that's the era the law was developed. And I think that we need sort of new law that conforms with the state of the world as it exists today. And I think that's really essential to the driving investment and driving.
Well, let me follow up, because your testimony, you really talk about developing a new risk-based regulatory framework that is specific to health information technology. With my remaining time, do you want to talk about that a little bit?
Sure. So, you know, I think it's essential. I go back to, you know, when I started my company, I raised 4 rounds of venture capital. And the process was very similar every time. Once you figured out the business model with the investors, they wanted to know 2 things. What's the IP issues? Are there patent problems? And what's the regulatory environment? And how's that going to affect their investment and the risk of their investment? And it happened every time. And also, so predictability, a stable environment where everything is codified and predictable is critical. And it has to be over the long term. I thought 1 round was going to do it, and I was all set, but we ended up with 4 rounds. And it's a long process. You need a stable environment for it to drive technology and innovation.
Chair, thanks, gentlemen. Now I recognize the gentleman from Texas, Mr. Green. 5 minutes for questions.
Thank you, Mr. Chairman. Again, thank you for calling the hearing and our joint telecom and health care. In July 4th article in Forbes, the co-founders of Google were asked if they would imagine Google becoming a health company. Their response was no. To quote Mr. Page, generally health is so heavily regulated, it's painful business to be in. Even though we do have some health projects, we'll be doing that in a certain extent. But I think the regulatory burden in the U.S. is so high that think it would dissuade a lot of entrepreneurs. In my experience, this is not an isolated sentiment from the tech community. Dr. Now, in your experience, is Google's view of innovation in the healthcare sector a common one?
Yes, sir. I think as I've had sort of lots of opportunities over the years when I was running my company to meet with other entrepreneurs and largely through forums, through our investors. And this was a common topic of discussion. The overregulation is an inhibition to investment and an inhibition to innovation. So having, as I just stated, a stable environment that's predictable and where we're not inhibiting investment and therefore innovation is important and I believe widespread.
Well, just from what some of us know, and this is such a good coordination of these two subcommittees because of what we can do with the combination of the high tech and the healthcare, it's literally could open up so many avenues for folks. I know there are some supporters of the current regulatory approach to healthcare that suggests that the regulatory uncertainty on the FDA is a proper approach, which I don't obviously agree with that. However, my constituents are concerned when leaders in the tech space like Google suggest health sector is an unwelcome place for innovators. Frankly, if that's true, millions of patients will be harmed, and this is a huge problem. Dr. Nile, what can we do to attract more tech innovators into the healthcare space, and can Congress play a role in helping to create more certainty for innovators in the healthcare space?
Yes, thank you. So I think that there are two things. I think the first thing reflects on my previous comment is we need an environment that, from a regulatory point of view, that drives investment, and that's all around certainty about the future, so that doesn't become a barrier, or we don't have, if you will, a risk premium on investments related to health IT. I think the second area is certainty or greater certainty about what the environment is going to be, the delivery environment is going to be, and how we're going to pay for health care in that environment so that there is greater certainty around what the market is going to be for these innovations. And specifically, I'm referring to, from a congressional perspective, is that CMS, with respect to the various programs that it promulgates, defines the payment model. And the private sector commonly follows what is promulgated by CMS. Providers are challenged when they have to work in part fee-for-service world and part accountable care world. And you need to reach a tipping point where enough of your business is in the accountable care world. I called it the coordinated care world. So it's worth making the investments in the technology to support that care model. To the extent that collaboratively between the private sector and the public sector, we can drive past a tipping point where investments in technology make sense and are economically sound, we will both help our healthcare delivery systems be more viable and successful, while at the same time driving better access, better quality, better patient safety, and more cost-effective care.
Thank you. My colleagues, we have a legislation called the Software Act, established a common-sense approach to regulating mobile apps and other health information technologies under the FDA. And our work is a work in progress, and our office has worked with both Ms. Blackburn, Mr. Butterfield, Chairman Walden, and others in a new draft that takes into account the feedback we've received from various stakeholders over the last few months. And I'd commend my colleagues on their leadership, but also the important issue. We could urge the chairman to address this in the 21st Century Cures. And that's what you just said is something I keep hearing. We need to have a payment system that reflects, are we going to go to the outcomes-based, or are we just going to continue with the same pay for procedure? And maybe we need to provide leadership from that. Mr. Chairman, thank you for having this hearing.
Chair, thanks, gentlemen. Now I recognize the gentleman from Georgia, Dr. Gingrey. 5 minutes for questions.
Mr. Chairman, thank you, Chairman Walden and Pitts, and thank you for holding today's joint hearing on an important nexus within the jurisdiction of the full committee. I'd like to focus my line of questioning on a topic that has been the focus of the committee for a long time, as SU was getting to that point as well. Innovation in health information technology, HIT. Dr. Niloff, you state in your testimony, and I quote, interoperable health IT is foundational to healthcare transformation. We cannot change the healthcare delivery model without it. Do you believe that we are on the path to interoperability, or are there changes to the law that we should consider as part of the 21st Century Cures Initiative?
Thank you, sir. I believe that we are on the path. I think it's a challenging and long journey. I think we can help accelerate that path with some of the suggestions I made in the response to my last question. I think a good example of that is the work that we've accomplished with the Commonwealth Alliance, where we've brought together essentially competitors to collaborate and work together to be able to move patients' health information with their consent around a healthcare system. We have pilots in place today. It's working. We have tremendously positive feedback from both patients and providers. So I think, sir, that we are indeed on the path.
Well, I agree with what you said, and I hope we are. But I'm very concerned. The RAND Corporation report that was published last month found that the main EHR, electronic health record vendor, with over half of the stimulus dollars paid out to medical providers going to their customers, was operating a closed platform, which in essence means that they cannot be interoperable. And Congress has spent, as we all know, something like $24 billion over the past 6 years buying products to facilitate interoperability, only to have the main vendor under the program, Epic, sell closed platforms. Do you believe that the federal government and the taxpayers are getting their money's worth subsidizing products that are supposed to be interoperable, but they're not? And I'll ask any of the panel if they want to weigh in on that. Yes, Dr. Jaron.
If I may, Congressman, thank you. One of the aspects that we've been pushing for when we discuss interoperability is medical device interoperability, and I mean very specifically home use medical devices, because interoperability can be many things. Health information data exchange between electronic health records, that's one aspect. Systems wide within a hospital, and that would include high acute medical devices, that's another kind of interoperability. But when you leave a care facility, the electronic health records incentive payment program right now that's run by CMS and the ONC, which you have quoted, the $24 billion, I believe it goes all the way up to $27 billion, not really much of that really engages patients and families in their care. As part of the meaningful use stages, stage 1, stage 2, and stage 3, in stage 1, they described that they were looking at potentially including uploading patient-generated health data into the electronic health record. That would be a way of interoperability. That happens right now because there are many companies that are actually doing that and allowing medical devices that are used at home, like wireless glucometers, for example, wireless sensors on inhalers, et cetera. That information can go straight into a portal. It can easily go into an electronic health record, but that's not something that's happening at all. Yeah. And part of that is because the meaningful use stages have not actually stated that very directly. Yeah. They should.
Well, Mr. Chairman, this committee has primary jurisdiction over the Office of the National Coordinator, ONC, and the High-Tech Act that is responsible for the tens of billions of dollars being spent on non-interoperable products. If the June 2014 RAND report is true, we have been subsidizing systems that block information instead of allowing for information transfers, which was never the intent of the statute. It may be time that this committee take a closer look at the practices of vendor companies in this space, given the possibility that fraud may be perpetrated on the American taxpayer. Furthermore, Mr. Chairman, as I see my time has elapsed, I would like to ask unanimous consent to include in the record an article from June 17, 2014 from iHealthBeat entitled Coalition Calls for Action Against EHRs That Block Interoperability. That gets, I think, Mr. Chairman, to the very point that I'm talking about.
Without objection, so ordered.
And with that, I yield back, Mr.
Chair,
Chairman.
thanks, gentlemen. Now recognize the gentlelady from California, Ms. Matsui. 5 minutes for questions.
Thank you, Mr. Chairman. Thank you for holding today's hearing, and it's been very, very interesting listening to all of you. American innovation is transforming healthcare, integrating science, medicine, and technology to provide individuals with real-time access to vital health information, much of which was previously unavailable outside of a hospital or a doctor's office. Smartphones are really creating pathways for virtual interactions between doctors and patients. Texting between doctors and patients is becoming more common. Now, telehealth is really at a critical juncture and increasingly become an integral component of the country's healthcare system. But one of the challenges of implementing telehealth is that there's no consistent standard. What we have is an inconsistent and often dated patchwork of state laws. States are currently considering and passing legislation addressing telehealth policies, which means there's a wide variation in how telehealth is defined. And this inconsistency hinders the national deployment of telehealth, hurting those who need care the most. And that's why I, along with my colleague here on the committee, Representative Bill Johnston, introduced the Telehealth Modernization Act to create a workable definition for telehealth services. It provides a strong incentive for states to adopt consistent standards to remove the regulatory barriers to telehealth. Now, you know, we move forward with all of this, too. I'm listening to all of this, and I want to ask a question here of Mr. Meisner. You talked about some of the ways that cloud computing is enabling medical research. And I think that cloud technologies are useful to foster innovation in research. And if we think really broadly, and I think about Amazon and all the data you have and all the information you have and what you're doing now in the cloud, how can big data impact the healthcare sector and be expansive? And I'd like to hear comments from the others, too.
Thank you, Ms. Matsui. I think there are about a dozen or so examples that I offered in my written testimony, but generally I think you're right on point that cloud services are an enabler of the biomedical field, both in discovery and development, but also in delivery. So I tried to give examples in each, but one way to think about this is a researcher today is typically constrained to thinking about questions that he or she may address only with the computing power they have available in their laboratory. And so they can't think about big questions because they don't have much computing capacity. But if all of a sudden available to them on a temporary basis, however much or little they need, is computing power, they now can think about questions that are far beyond what their laboratory constraints impose upon them today. And so it really is an enabler of that discovery side of things. And it does, again, enable researchers, scientists, doctors to focus on what they're best at and not have to worry about the technology that enables them.
Okay, and Dr. Riskin, I'd like your comments too.
Sure. We're a big data company, so we see a lot of data.
Right.
One of our partners, a large health system, sent us 1 million longitudinal records at one point recently and said, we want to understand the association of concepts. If you have a disease, diabetes, and you take a drug, is there any correlation with an adverse event there? We didn't have the processing power locally, certainly, to do that kind of effort. Fortunately, we do work with Amazon, and we have a good relationship with them. And we asked them, can you spin up 100 servers and 20 threads per server, and can we have massive processing power? And we crunched away at the numbers for a day. Cross-referencing every concept with every other concept. There's a challenge here. It's powerful. You get information that you may not want to have. And we work closely with the large academic centers to understand what information is useful and what information is not, and put useful information out into the community. But there's a great responsibility behind that kind of work.
Absolutely. And would you be analyzing a lot of this data yourself, or are you going to, as you contract out with the other institutions, have them take that responsibility?
In terms of what gets published, we think it's best for the health systems, the large academic centers, to create protocols and publish so we can crunch numbers and support them in their protocol. In terms of internal development, we certainly use information to develop the next product to influence patient care.
Do you see big data assisting in as far as the implementation as you get into the health care practices themselves, down to the very ground level?
I hope so. I don't see that happening in the short term, a year or two, but I sure hope that happens in the long term. It's one of the best approaches to reduce costs and improve outcomes in healthcare.
Okay, I thank you, and I went over my time. Thank you. I yield back.
Chair, thanks, gentlelady. Now I recognize the gentleman from Ohio, Mr. Latta, 5 minutes for questions.
Well, thank you, Mr. Chairman, and thanks very much for our panel for being here. It's been a very enlightening discussion that you've all given us today. And if I could start with Mr. Jaron, in your written testimony, you stated that another important component of any 21st century technology for 21st century cures is spectrum, which is the lifeblood of our wireless networks. Mobile health solutions are part and parcel of an enormous surge in wireless data usage, which is causing the spectrum crunch we are now all facing. And I was just, in this committee, we've had many hearings where we've heard about on the spectrum side and what's happening out there. One was that worldwide by 2017 there'd be like 1.4 mobile devices per person across the globe. Well, that's not really going to happen because we know that in some areas that the globe of the technological challenges. But I was also in another meeting the other day that they thought by 2017 in the United States alone there'd be 7 per person. So when you look at the numbers that are happening out there and also what you want to be doing with this whole technology, what can Congress be doing to help on this whole spectrum crunch to make sure that, the technologies can advance in the future on your end?
Thank you. More spectrum is the lifeblood. Spectrum is the lifeblood of mobile technologies and modern communications, modern wireless communications. And this committee and Congress in particular have actually shown a lot of leadership in trying to make more spectrum available. And when I mean spectrum, I mean licensed spectrum, shared spectrum, and unlicensed spectrum. I believe recently there was a bill introduced to help make more sense of the 5 gigahertz spectrum. We welcome that. mHealth is not unique to any particular band of spectrum. It's just going to add to the spectrum crunch. There was a task force that was put together by the former chairman of the FCC a few years ago, which I helped be a part of. And one of the findings of the task force was that through radiological imaging and video conferencing, spectrum is going to be really even taxed more within the next couple of years, because this is what is expected out of some of the systems and some of the services that we're discussing. So the more that we have available spectrum, the better it is for the user, because we are facing a spectrum crunch. The FCC has been very honest about that. So it is something that we at Qualcomm take very seriously. We actually have an internal challenge where we're trying to maximize the use of spectrum 1,000-fold what we can today. We call it the 1,000x challenge. So I believe that Congress is really taking steps to do that. Thank you.
Thank you. Dr. Nyloff, in the 21st Century Cures Initiative, the clinical trial process is one of the main focuses for the area. And in my home state of Ohio, I've toured many of the premier research institutions across the state. And I've seen firsthand the important work that these individuals are doing to find cures for many different life-threatening diseases. Can you give us some examples of how these new technologies will assist with the clinical trial process and make it more effective and efficient?
Sure. So I think that the first thing that is sort of the lifeblood of any trial is the identification of appropriate patients who would meet the criteria, specifically have the disease that's to be studied. And by having patient registries, having patients' diseases codified as structured data in these electronic systems allows for the easy or more facile and rapid identification of the large populations of patients that you need as candidates for these trials. So I think having that data available will expedite and increase the number of patients available for clinical trials. The second part in clinical trials is the ability to follow patients longitudinally and have good, reliable, structured data about the course of their disease and the different parameters of their disease to understand if the treatment under study is effective or not effective. And by having an electronic source of that data that captures the patient's clinical status and the response to the treatment under study in a repeatable, standard way is very helpful in assessing the outcomes of the study and the conduct of the trials.
Well, thank you very much. And Mr. Chairman, I see my time is about to expire, and I yield back.
Chair, thanks, gentlemen. Now recognize gentlelady from Colorado, Ms. DeGette, 5 minutes for questions.
Thank you very much, Mr. Chairman. I really want to thank the panel for this excellent presentation this morning. You might know that I'm co-chairing this initiative with Chairman Upton, and oftentimes we have people come in and sort of talk vaguely about how great it would be to have a revision of the system. But you really came in with some specific suggestions, and we appreciate that as we look later this fall towards actually drafting legislation. I just want to follow up with whoever wants to answer this on some discussion we've been having about interoperability. Everybody agrees interoperability is important, and we're striving for that even now under the system that we have. We're making some progress, but I frequently meet with smaller companies as well as individual physicians who are talking about electronic medical records. And the concern that smaller companies have is that they really don't have the resources to work with patient data and to get that interoperability. And I'm wondering, Dr. Nyloff, Dr. Riskin, and also Mr. Volkel, if you can sort of address what we do to, what we can do to incentivize this kind of interoperability throughout the system, not just with the larger players who can afford to do it.
So I think that the solution to that is through collaboration. And it's not necessary for each individual company to reinvent the wheel multiple times, but through, for instance, the Commonwealth collaboration that I referred to earlier is a mechanism where companies who might otherwise compete, be they large or small, can collaborate together and pool resources to develop technologies for interoperability that can then be broadly adopted.
Do you think there's any governmental role in making those things happen, Doctor?
I think the government role, again, at the end of the day, these solutions need to be paid for, and it all harkens back, if you will, to creating the economic environment and payment environment where the ultimate purchasers of the technology and the interoperability have a business case for purchasing it, which means aligning around a payment model where having that technology makes the providers successful in the payment model or care delivery model that they're operating under.
Dr. Riskin, do you have a perspective on this?
Yes, thank you. The question is a great one. There's a boundary between the electronic health record and the analytics system.
Right.
When I work in the venture community in Silicon Valley, we look at opportunities, and there's very little coming through of new electronic health records. It's not where the new value is. The new value is in analytics and population health and patient engagement. And we say for those companies to be successful, they need the data. So we will see company after company come in and say, we're just going to have the data and here's what we're going to do. We say, that's not fundable because you can't get the data. It's too expensive. So today, very expensive to get the data out. People are building custom interfaces into these electronic health records. That is stifling innovation. There is a government role here to say we paid for the data in the electronic health record and here is the information we want out. Today's approaches have very limited information for analytics and population health, ignoring the compliance issues and social issues and other things. So actually requiring broad data to be brought out would be powerful to promoting innovation.
Thank you. And Mr. Vogel, what about you? Do you have a view on this?
Yes. Earlier, Mr. Gingrich talked about Epic and their slow path to making their information available. And at the other end of the spectrum is Allscripts, which has made a lot of their data available to third-party developers. And the challenge has been is that I believe Allscripts and some of the other providers have been told, here's the format and the type of data you need to make available. And they look at their own system, and they built it in an era that didn't anticipate making that data available. And so it's hard work for them to build to this outside set standard, and it makes them not include stuff that Dr. Riskin would find very valuable. A different approach could be you have to make your data in whatever format you currently have it available. And if you do, entrepreneurs will be all over building Rosetta Stones to translate it between the services. But since you're telling the slowest moving, ingrained, less hungry technology group to build to something, it's slow. And Epic started 1.5 years ago to build a public API, and it's barely out the door.
Thank you. Thank you. Thank you, Mr. Chairman.
Chair, thanks, gentlelady. Now I recognize the Vice Chair of the full committee, Ms. Blackburn. 5 minutes for questions.
Thank you, Mr. Chairman, and thank you all for being here. We do appreciate the panel. The 21st Century Cures Initiative, the impact of technology in that is something that is incredibly important to our committee, and as you have seen from the questioning, we're working in a bipartisan way to address the needs that you all have, that patients have, and that the industry also needs. And being from Tennessee, we have appreciated the convergence and the impact of technology on healthcare delivery, and do feel like that some of the answers for not only healthcare delivery but patient quality of life are going to be achieved through these devices. And I know Mr. Green mentioned to you all the Software Act that he and I are working on. Ms. DeGette has joined us in this effort, and we feel as if it's a part of the backbone that is necessary. We're short on time. Votes are going to come up soon. So, Dr. Nyloff, I want to come to you and just have a couple of questions for you. The April 2014 FIDESIA Health IT report, are you familiar with that? Okay. They have a framework that the ONC would, among other things, create a health IT safety working center. Are you familiar with that plan for regulating some forms of software in health IT?
Yes, I am.
Okay. All right. Recently, Chairman Upton and a couple of our colleagues and I rode over to ONC to see where they think they're going to get this authority. And have you seen that letter? Are you familiar with that letter?
I am familiar with the content.
Okay. We got a response recently, and we felt like that they really don't know where they have that authority. And like so many times, agencies get into mission creep. And it concerns us. We feel like that the FDA wants to regulate our medical app products as medical devices, and they're not. And Congress, in its infinite wisdom, decided in '96 to update the FDA statute by creating the definition of a medical device in order to differentiate it from drugs. Before that time, there was no statutory difference between the two. So just like drugs, software is not a medical device. Medical devices are not drugs, and we think it's necessary to put some clarity in this structure. So do you believe that Congress needs to get involved in the fix? Should we leave it to the FDA? Should we leave it to the ONC? Because it's beginning to us to look like a misguided system of regulation, and we don't want this to run off the rails. So I would like to know what your guidance and your thoughts would be on this.
So, when the Act was last updated, if you will, technology as we know it today did not exist, and I think could not even have been contemplated. So we live in a completely different technology environment today than when that Act was written. And I believe that the Act should be updated with the framework as described, a risk-based framework, so that we have clarity for the community both today and clarity for the development community and the investment community going forward. So we're in a stable environment that will allow for innovation and us to make good progress.
I thank you for that. Mr. Chairman, I think it is just so vitally important that the FDA and the ONC work with Congressman Green and I as we work with the committee to come up with what a structure is going to be so that all of our low and moderate risk items can proceed to the marketplace, and things that are invasive and high risk have the oversight of the FDA, and that clarity is provided for this nation's innovators. With that, I yield back my time.
Chair, thanks, gentlelady. Now recognize the gentleman from Louisiana, Dr. Cassidy. 5 minutes for questions.
Dr. Riskin, I got some weird experiences here, man. I go to a banker's office or a lawyer's office, and they have fewer clerical workers because of computers. I go to a physician's office, and they are hiring a data enterer and someone to train the data enterer because of computers. Clearly, this is socking productivity. Now, both of you, Mr. Vogel and Dr. Riskin, suggested that there is minimal investment and little incentive on the interface side of it, whereas there's a heck of a lot on the backside. That's wrong. Now, when I speak to people, they wonder if the HITECH Act is not the problem, that by defining standards, we have stuck in amber certain systems. But as a doc, and I speak to docs whose productivity is down 25%, some of whom are taking the penalty. They're tired of looking at a computer screen instead of looking in a patient's eyes. Do you agree with that assessment, how the HITECH Act has been implemented is the, so to speak, we've met the enemy, it is us?
Thank you, Dr. Cassidy. Appreciate the question. Mixed agreement in that the...
And speak quickly, please, because I only got 3 minutes, ma'am.
The HITECH Act was powerful in terms of getting initial information in electronically. That's definitely needed. But the current processes of requiring information in certain ways has been excruciating for doctors.
So how do we unravel that?
Probably the way to unravel is through usability.
That's a little bit code for me.
Yeah.
Say usability, what do you mean?
The challenge is the doctor who's entering data right now, or their proxy, finds they're putting in information that isn't that useful, or they're being forced to put in information around billing that isn't clinically relevant. More of a focus on how can the systems be usable and how can we get the information
so
we
there's
care
an
about.
incentive apparently right now. I spoke of, I'm told it's stuck in amber. Entrepreneurs don't have any incentive to go in this space. Mr. Vogel just kind of suggested that. So what I'm really asking is how do we once more incentivize these entrepreneurs to begin to do this as opposed, get rid of the amber, so to speak?
To solve the data usability problem, the data entry problem, the incentive would require that EHRs be usable, and the EHRs would then need to work with companies to create usability. Right now,
I accept that, but you can't just mandate from on high. Washington likes to think it can do so, make it usable. There has to be some penalty not doing so, and it has to be some reward for doing so, not upon the doc, because the doc's already being penalized.
Agreed, and the physician community is less and less capable to push for usable systems.
So, Mr. Vogel, what would you say to that? Because you're nodding your head, you're in agreement, but I'm not sure I've understood yet how we get back to the entrepreneur in caring about this area.
I think you've hit on what's the economic incentive. And right now there's no way for a doctor to translate, I could free up 25% of my time and see more patients or deliver a higher quality of care. And so if the payments that the physician were able to receive or the way that they were compensated was linked to the quality outcomes like
No, but see, I'm not making my point. Yeah. The doc is willing to do this. The doc is taking the 25% hit. The doc is hiring the scribe at $12 an hour plus benefits. Mm-hmm. So I actually don't think it's the doc's problem. I think it is the vendor, if you will, who is not creating the interface because they're either not required to or there's no reward. Why not just foist it off upon the doc as opposed to us taking the lumps? I mean, do you see my point?
Yep, and I think they don't have the incentive because there's such high switching costs to go from one system to another that...
Well, how do we create that incentive?
So I think I don't know how you'll get an EHR to require to make their data interoperable, because that's the barrier to switching.
Do you agree with the critic that says the way that ONR has instituted this program basically does stick in amber so that the companies like Epic get high market share, but they have little incentive in order to create that better user interface?
Yeah, it makes them work towards a data
you agree
standard.
With that?
Yeah.
I got one more. Let me ask you one more thing. I read your testimony, didn't quite gather. You said there's strong economic disincentives for people to share data, but I didn't see you amplify that. What are those economic disincentives?
So if you ask Humana to give you a data set around linked comorbidities or protocols, it'll cost you $500,000 because that's what they charge Pfizer for it. And so if you're a startup or even a data analytics company that's trying to add a relevant data set that only payers have, you can only do it if you've got $500,000.
Gotcha. Thank you. I'm out of time. I appreciate it.
Chair, thanks, gentlemen. Now recognize the gentlelady from North Carolina, Ms. Elmers, 5 minutes for questions.
Thank you, Mr. Chairman, and thank you to our panel. Dr. Nyloff, I'm going to direct my question to you in the interest of time. We were just discussing, kind of following up on some of the discussion. We're talking. I certainly see all the benefits to patients on health IT. This really is an area that of obviously much need into the future. But there again, keeping in mind that we know that there are all the positives, what are the barriers? And I think we were just talking about some cost issues here for integrating the systems. Do you see this as an issue too? And are there other barriers that we need to be aware of?
Sure. So I think that the main barrier and the main challenge today, as we've discussed, is interoperability and continued innovation. Mm-hmm. And I think that we need to have the right payment model in place to drive the purchase of these systems. We need our delivery systems to have sufficient alignment of their different contracts that they're operating under. Mm-hmm. So they're doing population health, coordinated care on a significant portion of their population, that they can make the investment both programmatically and technologically in these type of things, because that will drive innovation as the market grows.
And when you say they, are you talking about the physician themselves, or are you talking about?
I'm really talking about at the health system level. Okay. I think much of this technology, because physicians are now working in organized systems of care, mm-hmm. where they're part of an integrated network, and we're really driving to coordinate care from the inpatient arena to the outpatient arena to long-term care, mm-hmm. that really what we're talking about is health systems making purchases of technology, and not just electronic medical record technology, but enterprise registries to drive preventive care and manage patients with chronic illnesses, care management systems where they use technology to identify high-risk patients and then have skilled nurses manage those patients. Mm-hmm. That those are the types of technologies and related programs that are ultimately really going to drive us to a delivery system which is going to drive real improvements in health.
So that would be, just actually playing into another question. So I'm just assuming that that's kind of the path that you see us taking as we're looking for the 21st century cures, and how we as legislators and how we in Congress can help that effort. Obviously, you see that as an effort too when we're moving towards advancements in medical technology and curing disease and moving forward that way. Is that?
Yes. I think that it would be helpful if, as Congress considers sort of healthcare for the 21st century, that they think about healthcare in the context of not how we're delivering care today, mm-hmm. but in a framework that thinks about the context of how we're going to deliver care in the future in a more optimal model. Mm-hmm. Think about how we're going to have systems of care where everybody talks to each other, where when a patient moves from the hospital to a skilled nursing facility, their record moves with them, and it's not, you know, it's not, I'm thinking about a family instance, but where, you know, an 80-some-year-old mother ends up having to be the major coordinator of care for her 93-year-old husband because it's not happening electronically and the health system can't manage it. And I think that's really what we have to think to is what sort of care model, system of care that we're going to move to that makes it not just better care but better experience for patients and families, and how we're going to, how Congress can modify the law to drive that type of system of care which will benefit all Americans.
Thank you, Dr. Nyloff, and thank you, Mr. Chairman. I yield back the remainder of my time.
Chair, thanks. The gentlelady now recognizes Mr. Butterfield. 5 minutes for questions.
Thank you very much, Mr. Chairman, and thank all of the witnesses for their testimony today. I want to commend you, Mr. Chairman, for the subject for the hearing today, 21st century technology for 21st century cures. I like that, and I hope that as the session that moves along this year, we can continue to develop some ideas. To all of the witnesses, and I can't call on each one of you, but whoever feels the most comfortable, I would ask that you respond. We know that certain population segments, including seniors and Americans with disabilities, are less likely to adopt broadband at home. Do the broadband enable innovations that we have discussed today help these Americans get online and receive all the benefits of the applications we're discussing today? That's not fair to you. I guess I should have called on one or two, but let's do it this way, and then I'll call on someone next.
Sure.
Yes.
So the answer to broadband, the answer to big data, you know, when we're talking about big data, and I hear the theme coming up quite a bit today, part of that is connectivity. Without connectivity, there is no real big data, whether it's wired, wireless, or mobile. Increasingly, it's becoming mobile, and that's obviously represented in the figures I gave at the beginning, 355 million users in the U.S., 7 billion in the world. So I believe that through products like those of Amazon, products like the chipsets that Qualcomm produces and go into those products, those consumer-facing devices, et cetera, they're getting out there. I believe the FCC quoted that over 95% of the country is now covered by at least one mobile broadband provider. More needs to be done, both on spectrum. Also, I know that the FCC is working hard towards reaching disparate populations through their rural broadband program. But I believe that we're getting there. We are getting there.
All right. We have a buzzer to go to the floor, so I'll just ask one more, Mr. Chairman. Telehealth programs are critical to communities in rural areas like my district in eastern North Carolina. East Carolina University, for example, has set up a telehealth opportunity at clinics throughout many rural communities that enable constituents to receive specialized medical care without traveling long distances. And I know all of you are familiar with this, and you are looking forward to the next generation of technology. What are the major challenges, such as broadband access, that rural communities face in fully utilizing telehealth opportunities? If each one of you could just do a couple of sentences. Let's start with Mr. Vogel. Yes.
Well, I think probably they're more qualified down there, but I think it's the mobile devices are beginning to take over what that capacity is. It's less, cables into the home, and it's what used to be wired is now wireless. So as the Qualcomm guys continue to do their good work in 1,000x the bandwidth.
Okay.
If you wanted me to answer, Mr. Butterfield,
sure.
Mr. John is exactly right. Connectivity is the key. And we've always heard, at least for the past 2 decades, that telehealth was going to be a major driver of the need for connectivity in rural areas, and now it's here. And so I think the concept of ensuring broadband deployment nationwide, including in rural areas, is extremely important, not just for telehealth, but especially for it.
To answer from my perspective, I actually have an appointment in a safety net hospital. I'm very familiar with the access issues that occur. And I would say connectivity is critical, but patient engagement is just as difficult. Whatever modality you're using to reach your provider, if the patient isn't engaged in their care, and typically rural or safety net communities are more difficult to engage, they won't be able to work with that modality.
And I know that we're almost at time, but one thing that I'd like to mention, so Qualcomm sponsors many things. We have a program called Wireless Reach. One of our recent projects was delivering care in a Native American area near Flagstaff, Arizona. And there were issues with being able to get mobile broadband in those areas. There was no connectivity whatsoever, but there was one operator in particular that actually was able to reach this population. And what we did was we provided telephones, smartphones that connected with home use medical devices such as medical grade weight scales and blood pressure cuff monitors. And what happened was that a person with congestive heart failure would use these devices. It would connect through the smartphone, go into the hospital, and then a series of nurses and other care providers would actually develop a workflow and be able to inform the patient of when things were going badly. We were able to reduce hospital readmissions through that, and it proved very well. So,
Chairman is tapping on his microphone. That's our clue.
Mobile broadband is a very important thing for disparate populations.
I get it.
The chairs.
I get it. Thank you.
The gentleman's time's expired. We're in the middle of a vote. We've got 10 minutes left. We're going to try to finish here. Mr. Griffith, you're recognized 5 minutes for questions.
Thank you very much, Mr. Chairman. Thank you all. This has been a very educational hearing. As you can hear, there's bipartisan support for trying to figure out how we go forward. I've heard all kinds of things, figuring out the payment model when we're using new devices that you may not even have to go in to see the doctor on, and electronic health records. My concerns parallel those of Ms. Blackburn when she talked about devices. It was sometime a little over a year ago, we had an FDA representative in here, and I asked them about this $8 hack that had been used in Africa to send photographs to a hospital in the United States. You had a team of Canadian and I think Swiss doctors working on it, and they were able to identify parasites out of the stool of children and get a diagnostic fix, figuring out which parasite it was and do the treatment the next day. I said, would this be a medical device? And the answer was, yeah, if it's diagnostic, it's a medical device, even though all they were doing was taking a picture on a smartphone with an $8 hack. Because it was being used diagnostic, the FDA thinks it's a medical device. So I think it's very important that we pass language that we can approve in a bipartisan way that clears that up, so that, as she said in her statement earlier today, if it's a truly, something that's invasive, we want FDA making sure it's safe. If it's just diagnostic, we want to make sure that we get it to the market. And Mr. Jaron, I noticed, and it's in your written testimony and in your oral testimony, you mentioned like 15 devices that you could use that would give you some diagnostic capabilities without the healthcare provider being present. Are you all finding that that FDA is worried about that or spending a lot of time on that?
Well, actually, the X Prize included the FDA originally, so that way we wouldn't land into those issues and lack that clarity, because that was definitely an issue that we were considering, whether or not this would be obviously a medical device. So the FDA joined the project early on. I believe that Dr. Shurin, who may have been the person that you were referring to, actually even put a video on the FDA website about their involvement with the X Prize. So I'm hoping that when everything's said and done, we'll all be on the same page. One thing that I would mention, you have an excellent example of the kind of clarity that was needed, and it still needs. There's never not enough, right? Because that exact example is something that they actually ended up putting into the the final guidance, by saying that those mobile apps that can be used to visually augment, whatever a provider is dealing with in a diagnosis, would not be regulated under their enforcement discretion. So we, it was very helpful. Again, Congress is very helpful, because when you ask those questions, I believe the agencies really do pay attention and listen. And the FDA, in that very specific instance, did exactly that. They did release the mobile medical apps guidance document. I believe that FDASIA tries to deregulate 95% of what they say very specifically, most CDS products and mobile medical apps and health IT software, but now it needs to be codified.
And we have to cut you short because you've got to leave a little time for Mr. Bilirakis to get a question or two in. I would say that not only is that important, I'm glad that they were listening, but that telemedicine is going to be very important. I represent a rural district, and it's going to be extremely important in the rural parts of this country. Thank you so much for that, Mr. Chairman. I yield back.
Chair, thanks, gentlemen. Now I recognize Mr. Bilirakis, 5 minutes for questions.
Thank you. I appreciate it, Mr. Chairman, and thank you, Mr. Griffith, for keeping it short. I really appreciate it. I want to go quickly, too. With regard to the cloud, unfortunately, 10% of the agencies have adopted cloud in the federal government. So it hasn't really been a success on the federal level, unfortunately, but in the private sector, has rapidly adopted cloud-based solutions. And I know Representative Matsui actually touched upon this, but I have a couple questions. What are some of the barriers to the adoption and expanded use of cloud-based computing and cloud-based storage in the medical space, and how can we facilitate the expanded use of cloud? What are some of the laws that need to be examined because of the way they interact with the cloud computing? And anyone in the panel can respond. Doctor?
Cloud expert should start, probably. Well, thank you, Mr. Bilirakis. I appreciate that. So, in our experience with Amazon Web Services, the take rate isn't as great as we'd like it to be with government agencies, but it is changing. And as I mentioned in my testimony, we already serve many around the world. But in the federal government, there are areas where Congress could lead by example, either through legislation or working in their oversight role over agencies to ensure that agencies do use cloud when it makes sense to. Right now, sometimes agencies feel constrained to buy only traditional hardware and software and pay their own in-house people to run it, and that it turns out to be highly inefficient. And so hopefully Congress, through the two acts that I mentioned in my testimony, could, including FITARA, could encourage the government use of cloud to the benefit of our taxpayers, of course. Thank you.
Anyone else on the panel? Okay, I'll get on to the next question. With regard to the medical devices in the dialysis world, they've remained largely unchanged. You'll agree with that. If you were to need kidney dialysis, you'd basically be using the same device that your parents were using. There's not been any large innovations in that space. However, in the world of consumer electronics, there have been continued innovations in this space. Television today, televisions are radically different from televisions in the 1990s. Cell phones today are different than they were the ones in the 1990s. Tablet PCs are different than the laptops and notebooks from the past decade. So my question is, how is it that we can have rapid innovation in consumer electronics with lower costs for consumers, but slower innovation with higher costs in the medical space? Is it the cost of the excessive regulation? Is it the higher barrier to entry? How do we encourage shaking up the status quo? And whoever would like to begin, please.
I actually will take it only because I'm aware of a pilot project that is actually part of the Center for Medicare and Medicaid Innovation Challenge Grants, which is being conducted at the George Washington University Hospital in consult with a company named Delir and a company named Baxter. And a number of other partners, and it deals with kidney dialysis in one way or another. So I believe that community is definitely listening. They're really looking into things like remote patient monitoring, et cetera. But if I step back for a moment, I think one of the largest barriers to adoption for this entire field are the outdated rules that we have governing reimbursement for services. Particularly when we talk about remote patient monitoring, it automatically gets lumped into something called telehealth reimbursement, and it's not necessarily the same thing. Under the telehealth rules, you have to start off from an originating site of care that CMS stipulates. It has to be a specific disease condition. There's only about 20 or 25 of them. It can't happen in a metropolitan statistical area. It has to happen in a health shortage area. It has to be live voice and video, which removes automatically all the stuff that we're working on. It's it's incredibly restrictive. So according to the American Telemedicine Association, doctors are only able to access between 5 and 8 million with an M worth of reimbursements for telehealth consults. You know, the CMS budget is near $800 billion. So I would pause to think that some of that could be targeted towards incentivizing the uses of these types of equipments and services, because the issue is this: if I'm a hospital or I'm a health plan, if I'm not being reimbursed by my largest population, which happens to be Medicare, I'm not going to be incentivized to adopt those technologies, and I'm not being paid to use or provide services that I'm not going to be paid to provide. So I think that's a real huge barrier to adoption. And then that folds into, of course, the incentive payment program, which has done a good job of incentivizing the use of electronic health records, but there's no aspect that actually allows for patient-generated health data to go into that electronic health record. So the patient is really literally cut out, except when he walks into the facility. And then you've got the situation that your colleague was mentioning, where we have a scribe, you know, typing stuff in while the doctor and the patient discuss their care. So it's a real complex issue, but I think that those are barriers to adoption.
Thank you very much. Thank you, gentlemen, for your testimony. I yield back, Mr. Chairman.
Thank you. Thank you again to the witnesses for sharing your expertise. This has been a very informative hearing. I'm sure members will have a lot of follow-up questions. We'll submit those to you in writing. We ask that you please respond promptly. I remind members that they have 10 business days to submit questions for the record. Members should submit their questions by the close of business on Thursday, July 31st. Another very important, informative hearing. Thank you very much. Without objection, the subcommittee is adjourned.